And welcome to the Dr. Bob Show. 3 million people in the United States have cataract surgery every year to improve their vision. Is there anything new? What are cataracts? Can we prevent cataracts? Why do people get cataracts? How do you know if you've got a cataract? How does the doctor make the diagnosis? When you have cataract surgery, what's the surgery like? And are there new advances in the surgery? We'll be going through advances in cataract surgery. My guest is Dr. Darin Smith. Dr. Smith is a board-certified ophthalmologist, eye doctor, MD doctor, and he does cataract surgery every week of the year. He'll be answering our questions, and especially will be telling us about the new kid on the block that has lots of advances and important advances for you as you recover from cataract surgery. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show, and I'll be learning what I can do to improve my eyesight and see if I need cataract surgery. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Darin Smith, board-certified ophthalmologist, IMD, and we're talking about newer treatment or advances in the treatment of cataract surgery. Darin, welcome to the Dr. Bob Show.
Thank you for having me again, Dr. Bob.
Let's get down to basics. It's like football. You get down to blocking and tackling. What are cataracts?
All right, so basically, all a cataract is your natural lens that you've had since birth that's gotten more progressively cloudy over time. So as we get older, the lens it continues to grow, but it can't grow bigger, so it just grows more dense. And so as it gets more dense, it just gets cloudy, and when it's cloudy, we just call it a cataract, and when it gets bad, we take them out.
Are they easy to take out? Easy is not a good word. Are they easy to take out?
They're not too bad. I mean, I think from a surgeon standpoint, anyone who's been doing it for a while, it's not too hard of a surgery to do. And from a patient standpoint, it's really one of the easier procedures that patients are going to have as far as a surgery goes in their life. It's 10 minutes, minimal discomfort, highly effective, and generally speaking, a very happy thing.
I can remember when people have cataracts, the lens is cloudy, and so people's vision, looking at colors and looking at things on the outside, are diminished. And when they get the cataract lens replacement, it's like, wow, I never knew the world was so bright. So it must be a nice thing to be able to do to help people that have cataracts.
It's very fun. Well, and a lot of times, the reason that they have that wow moment is because it happens so subtly and slowly over time. A lot of times they don't even realize what they've been missing until they get one done, and that's when you get the, oh my gosh, what have I been missing?
This is like a clear world that I'm looking at.
Yeah, so it's a blast.
Are there problems with lens replacement? Oh, first of all, where is the lens in the eye?
Okay, so quick anatomy, the cornea is the clear dome of the eye. That's what, if you wear a contact lens, that's what you put a contact lens on. The colored part of the iris, the colored part of the eye is called the iris. So the lens sits directly behind the iris. So when we do cataract surgery, we have to dilate the pupil. That just makes that pupil, the dark center, really big. It gets that iris out of the way so we can get to the lens behind that.
And what do? Do you cut the lens?
So we use what's called an ultrasound. The medical term is phacoemulsification, but basically it's ultrasound with a vacuum. And so we make a very small incision. Depending on the surgeon, our incision size is only 2.4 millimeters. It's very, very tiny. So tiny that you don't need sutures or stitches. So it's self-healing.
Heals itself.
It heals itself. And so we just use the ultrasound to break that cataract up into small little bits and suck it out.
Do you have different types of lenses that you replace?
Absolutely.
The
So
clouding one?
there's basically 4 different kinds of lens implants that we can put inside the eye. I would kind of group them into the 3 traditional, and then there's the one new one that you kind of mentioned. The 3 traditional lenses would be what we call a standard lens, and different doctors might call it something different, but it's basically the lens implant that insurance pays for.
When it goes into the eye, how does it know how to flip open or to stay where it's supposed to stay?
So we leave behind at the time of surgery something called the lens capsule. So the lens capsule is holding your natural lens in place to begin with. And so what we do actually when we're doing the surgery is we make a little opening in that capsule, we remove all the lens material from within it, and then the lens capsule is actually what holds the lens implant in place.
So has this been the standard, most common type of lens replacement?
Yes, sir.
Let's go through 2 more.
All right, so the next thing as far as the traditional lens implants would be something called a toric, T-O-R-I-C, a toric lens implant. And that's for treating a lot of astigmatism. So astigmatism is something where, I mentioned the cornea before, instead of the cornea being perfectly spherical like a ball would be, it's a little bit more oblong. Say like a basketball would be a sphere versus a football, which is a little bit more a cylinder.
So you have different lenses for different eyes. Any further advances until we're going to get into something new?
So and then the third traditional type of lens is what's called a multifocal lens. And those lens implants have been around for pushing 25 years, or excuse me, pushing 20 years. Came out in the early 2000s. And they can give distance and up close vision. So a standard lens basically just helps for distance vision. Same thing with the toric lens, but the multifocal lens can actually give some distance and up close. And there's some, advantages and disadvantages to all those options.
Do people have to get glasses sometimes, even though they've got a brand new golden
It's very
lens?
common, yes. And so the general belief is, hey, I get cataract surgery, I never need glasses again. And that's just not 100% accurate. Although I think you and I were talking before that 3 million people get cataract surgery a year. Even half of those people don't need glasses anymore. That's a lot of people walking around every year who don't need glasses. So it's very common to at least need some reading glasses, sometimes a light pair of bifocals. And a lot of that depends on, too, again, we mentioned astigmatism. So as an example, if someone has a lot of astigmatism and doesn't get it treated with the lens implant, they're going to need glasses to treat that. So not the end of the world.
So when you have normal cataract lens replacement, what can go wrong with that we can now correct?
Yeah.
I'm sort of putting a carrot out there.
Yeah. So all those lens implants come in different powers. And so we choose the power of the lens implant based on measurements that we do in the clinic before surgery. But once that lens implant's in there, it's basically in there and you get what you get. And most of the time we've gotten very good at being very accurate with those lens implants. But sometimes we're off. And the more off we are, the more likely someone is to need glasses or contacts or some sort of other treatment.
Yeah, but you all are so good at putting glasses over something that wasn't 100% perfect, that really wonderful vision should be part of everybody's life as long as they see the eye doctor and get that taken care of. There is a new light adjustable lens implant. I want to talk about that when we come back, because it apparently is a new guy on the block that offers lots and lots of advantages for people so that they can adjust anything that's not perfect on the first time around.
Yes, sir.
A lot of information. You're going to want to stay tuned. Wouldn't it be great if you never had to see your doctor because you were so healthy? Hello, I'm Dr. Robert Overholt, and I'm here to discuss the governor's initiative for a healthier Tennessee. Remember to be exercising on a regular basis and eat better foods, more fruits, more vegetables, and if you're smoking, stop. I'm Dr. Robert Overholt for a healthier Tennessee. We're talking with Dr. Darin Smith, board-certified ophthalmologist, IMD, and we've been talking about cataracts, cloudy lens, take out the old, put in a new. There's 2 or 3 different types that can be put in. And one of the problems is when you put it in, it's there. Now we have the option of being able to adjust what's going on with the lens after surgery. We call it light adjustable, and I'm going to stop right there because I'm getting way over my head. What is the new lens implant, and how does light help you, the doctor, readjust what the patient needs?
Yeah. So it's a great question. It's very a very fun new technology that's just been available to us in the last year and a half or so. This technology has been around for a while in Europe, so people will ask me, well, I don't want to be the first one. It's like, well, actually, it's been around. So, but the FDA just approved its use in the U.S. maybe a couple years ago, year and a half, something like that. So anyhow, the lens implant, okay, it's just like any other lens implant. It goes in just like normal lens implants. So it, technically speaking, from the cataract surgeon standpoint, there's not much difference, okay? What's neat about this lens implant, there are molecules, all right, in the lens that will, when they get hit with a certain wavelength of UV light, a certain very specific amount of ultraviolet light, those molecules that are like this will connect. Okay, and so that as they connect, it changes the shape of the lens, and as it changes the shape of the lens, that changes the power of the lens.
So you can go with the ultraviolet light treatment and readjust what the lens is doing, where you can make it where the person can, instead of seeing 92% better, they can be 100%
yeah,
better.
it's for the very first time, really in the history of the world, that we can actually change and fine-tune someone's vision after cataract surgery.
So if I had cataract surgery 10 years ago and I came in and said, hey, I want you to rearrange the molecules in my new lens, what would you say?
Unable.
Unable to do it.
Sorry, but no.
You were 10 years too early.
Yeah.
But people that come in now, one of the options you can give them is the ability to have adjustability of the lens. Is that the proper terminology?
Yeah, I think that's a very good way to put it. One thing that when I'm counseling patients about what their lens implant options are, some people are not good candidates for different lenses for one reason or the other. The only reason, well, the main reason someone wouldn't be a good candidate for a light adjustable lens is if the pupil is just too small. So when we do the adjustments, we need to have a big pupil. So the pupil has to get to a moderately large size when we dilate it, but that's usually no big deal.
Is there a way you can get the iris out of the way?
Well, during surgery, yes, but not for the treatments. But that doesn't come into play, very often. But as far as the light adjustability goes, when we're doing, we put the lens implant in, here's how it works. We put one lens implant in, assuming we're doing 2 eyes, we'll do the other eye, a week or 2 later. And then starting about 3 weeks after surgery, so we want to let it get healed up a little bit, we start doing adjustments. And people will get between 1 and 3 adjustments. Okay, so you have to get 1, maximum of 3. Most people get about 2 adjustments, and then there will be 2 what are called lock-in periods, lock-in treatments.
So there's one that puts the cap on.
Right, and the reason for that, as I mentioned, those molecules, there's only so many of those molecules in the lens implant that you can connect, and once they're connected, they can't change again. They can't unconnect or change. So there's only a certain amount of movement that we can make with the lens implant, and then once we get someone where we want them, well, we don't want it to change. So that's what the lock-in periods or lock-in treatments are basically using up the rest of those little molecules, so that once it's set, it's set. So one thing to know, it's adjustable until we get where we want it to be, but it's not infinitely adjustable over years and years and years. So once we get it set, then it's set.
Okay, once you get it set, it's set, meaning 5 years down the road, if you say there's something going on, all the fixing's been done.
All the fixing's been done, yes.
So how do you bring the patient back and decide if they need fixing?
So everyone will get at least one treatment. So it really kind of comes down to what someone is seeing, you know, and how they're doing. If someone comes back after a treatment and they're ecstatic, well, guess what? Let's lock this down.
Yeah.
You know, and if they come back and they're happy, but we check and see, like, well, you know what? Hey, there's still a little of astigmatism left, so we can actually treat some astigmatism with this, and nearsightedness and farsightedness. So we can tweak this, you know, and even if someone's happy, it's like, well, we can make you a little bit better. Let's give it a try.
So how long do you have before you have to quit tweaking it? Do you have a year, 6 months?
Well, so basically you've got, you know, the 1 to 3 treatments, which need to be separated by about 3 days. So when we do the treatment, it actually takes a couple days for those molecules to actually connect. So you don't see the result immediately. You see it over the course of 2 or 3 days. So you have to wait at least 3 days. In my practice, practically speaking, it's usually once a week.
If somebody is an ideal patient and they have responded ideally, what is the end result? What did they tell you after they've been back 2 times and you've readjusted things with ultraviolet light and everything looks great, and then you've capped it, you have to bring somebody back to lock it in?
Yes.
And after it's locked in, what's the patient like?
So I have, my experience with the lens overall has been extremely positive. I think the lens implant is absolutely fantastic for distance vision. So I think there's a very high probability of getting someone seeing 20 or 20 or very close to it, in the 90% range. But it's interesting. The lens implant is not a multifocal. Remember, we mentioned the multifocal lenses to give distance and up close. It's not a true multifocal lens, although it does have what's called an enhanced depth of focus. So the depth of focus is how far from here to how far out can you actually see without changing the focus. So it does have a good depth of focus. Some people see amazing 20/20 or very close to it, distance and up close. Some people don't get quite as good as up close as you would want them to. Usually, I'd say most of the time, people can read their cell phone and you know, see the food on their plate, do what I would consider, you know, just mundane up close vision, you know, functional near vision, where you're not going to sit down and read a book for hours, but you can kind of get through a day.
You may still need reading glasses.
So I think the biggest and most likely reason for needing glasses after light adjustable would be some reading glasses, especially for prolonged reading or real fine print.
How about seeing somebody back in the back of the church, up in the balcony?
That should be no problem.
That should be no problem.
I would think usually that'd be no
So
problem.
if you're at a basketball game and somebody's slam dunking, you should be able to see the net and the ball go through the net?
I would think you should see pretty well. Some people will do a very small amount of what's called monovision, where you'll make one eye maybe just a little nearsighted, and that might knock the distance vision down ever so slightly, but give someone better up close. And that's one of the neat things about these adjustments is we can try that. You know, someone can try it on for size, and then go back if they don't like it like that. So it really kind of comes down to what a person's desires are.
Hello, I'm Dr. Bob Overholt, here to encourage you and your family to get out and play in our Knoxville area parks. Knoxville has dozens of parks and more than 85 miles of trails. There are picnic shelters, ball fields, tennis courts, and disc golf courses, dog parks, fishing ponds, and skateboard parks, trails for hiking and mountain biking, boat rentals, you name it, Knoxville has it. To find a park or greenway near you, visit OutdoorKnoxville.com. And get out and play. It's good for your health. We're talking with Dr. Darin Smith, board-certified ophthalmologist, and we've been talking about new advances in lens replacement for people that have had cataract surgery. Brand new, amazing results that the ophthalmology is giving the patient. Looking into the future, what do you see in the future with treatment of diabetic eyes?
So I would say, just as a little public service announcement to all your listeners, if you're diabetic, you need to be getting those eyes checked.
How often?
At least once a year. And if there's if there is a little bit of retinopathy, signs of diabetes in the back of the eye, that's what we call that, is diabetic retinopathy. Every 6 months or sooner, just depending on
what they find, if there's anything new.
Yeah.
So if you get to be an old fogey like Dr. Bob, how often should you go see just routinely for a routine eye exam?
If nothing is going on, once a year.
Okay. So I've got a little bit of dry eyes. I think that's not an uncommon thing. But my vision seems to be pretty good. So I'm coming to your office once a year and say, take care of me, because I've only got two eyes, and you want to take good care of those two eyes. Anything new as far as macular degeneration goes? There's a wet and a dry form.
Yes.
There are some new biologics, we're calling them, to treat with. Is that something you can see being part of the future?
So there are always new medicines coming out. Basically, the difference between dry macular degeneration and wet just means that there's blood or fluid on the wet. And so they use usually injections in the eye in order to help dry that up, get rid of that fluid. Macular degeneration, the wet form especially, used to be just basically a death sentence for your vision.
Yes.
There were very, very poor treatments. It was laser, but none of it was effective. So nowadays we can capture, if we find and diagnose even wet macular degeneration very early, people can do quite well. But it requires injections in the eye, which I know sounds awful.
It does sound awful, but when you talk with people that have had a needle in the eye, they say,
It's not nearly as bad as one would imagine. You put the word needle and eye next to each other, and that's going to evoke some anxiety.
Yeah, well, it does. But the people that go through it say, there's nothing. I go once a month or however often they need, and I get the injection into my eye, which even to me would sound, that's big time. And it is big time, but it's wonderful to have that available for patients, knowing that that treatment can save that eye so that they won't have total blindness later on. So we've got diabetic retinopathy, we've got macular degeneration. What else goes wrong with the eye? How about the iris and the cornea?
So, things can go on with the iris and the cornea. The cornea, some of the more common things would be, for example, there's something called keratoconus, but that's more of a developmental thing that doesn't usually happen later in life, but it's something that can really affect your eyes. The biggest thing with cornea is corneal infections or trauma. If someone is wearing a contact lens, there's a lot of contact lens wearers out there. Sleeping in your contact lenses drastically increases your risk for corneal ulcers, which can be devastating. In fact, in the news not too long ago, there was those tainted eye drops that people were getting something called pseudomonas.
Yes.
And going blind from and dying from. Well, you can get pseudomonas just from wearing contact lenses. So it can be a really big deal. I think contact lens use is fine. Gets done safely by millions of people, but you really don't want to sleep in them, if at all possible.
So I think what we're saying is take care of your eyes. You've got eye specialists, ophthalmologists. They're there to help the patient, but the patient's got to make the appointment to see the doctor. And if there's any symptoms of any kind, the eye doctor will help find out the cause, the treatment, and get rid of the badness and leave the goodness.
Well, I think that's very wise. And the one thing that I would just really stress is about being seen. There are a number of things that don't have any symptoms at all early that get caught on routine exams that you're not even, you know, we look for those things, but you're not expecting to see something, but you look back and you go, hey, has someone ever mentioned anything about glaucoma? Or hey, do you have high cholesterol? Because I see a cholesterol plaque in your arteries. You know, so there's things that we see incidentally just on a routine exam that can save someone's life sometimes, and certainly their vision. So it's worthwhile being seen.
Darin, you're amazing. Remember those 4 things that we want? Exercise. Does exercise help the eyes? Exercise helps everything. It helps clean out the vessels that are supplying nourishment to the eyes. Be sure you're getting 7.5 hours sleep. Give those eyes a little bit of rest every once in a while, and don't sleep with your contacts. Eat well, eat nutritiously, less food, more fruits and vegetables, and most of all, that laughter in your life. Spend a lot of time laughing, enjoy yourself, you'll stay healthy, and you'll be glad that laughter is part of your life.